Good afternoon, everybody. Welcome to ADAA's professional webinar, The Interplay Between PTSD and OCD, Treatment Considerations and Tactics. We are honored today to have as our speaker, ADA member, Dr. Eda Gorbis, PhD, LMFT. And Dr. Gorbis is the founder and executive director of the Westwood Institute for Anxiety Disorders in Los Angeles, California. She's also a clinical assistant professor at the USC Keck School of Medicine. The Westwood Institute is often called an intensive center of last resort for obsessive-compulsive disorder, OCD, body dysmorphic disorder, BDD, and other anxiety disorders. By integrating treatment methods with a multidisciplinary team of experts, Dr. Gorbis has brought hundreds of people with prior treatment failures to normal functioning. Her expertise has been prominently featured on programs such as 2020, 60 Minutes, and MTV's True Life. She has given over 170 conference presentations on topics related to her intensive treatment of OCD, BDD, and anxiety disorders around the world. Dr. Gorbis, we're delighted to have you here today, and I am going to now stop sharing and you can share your screen.
Thank you very much, Ms. Bram. Good afternoon, dear friends and colleagues. So I will be presenting today on interplay between PTSD and OCD and talk about the treatment tactics. So first, what we're going to do is I'm going to talk a little bit about the background, how the idea came to me. In 1991, I was designated by Dr. Alexander Bystritsky, the head of the Anxiety Disorders Department, to provide tests, diagnostic tests to all patients coming to OCD day treatment program. And over the year, which was a very cumbersome job, but I learned a lot. And thanks to this experience. So as a background, I wanted to let you know that during this time, I have noticed that there is a certain category of patients with the background of trauma that later on triggered OCD, and they do respond to the treatment. However, they relapse immediately. And I have brought it to the attention of directorships at UCLA, and then Dr. Bystritsky agreed to do a study with me for 10 people. I'm going to talk about the epidemiology of OCD. It's a neurological illness, and it is characterized as a syndrome by many, especially by us while I was working at UCLA, and even now when professionals discuss it. It is characterized by, and it's not a connotation of obsession like Calvin Klein perfume or, for example, I'm obsessed with the woman or man, or this word is a beloved word for all the television writers, for all the shows, and for book writers. However, this is not that type of an obsession. It is characterized by recurrent thought, image, impulse, feeling that causes marked anxiety and distress, to the point that as a result of this marked anxiety and distress, the individual is trying to engage in compulsive behaviors or avoidances. It is accompanied, when they have insight into it, by efforts to ignore, suppress, neutralize the thoughts to no avail, because compulsion actually is negatively reinforces the syndrome in itself. I will give you an example of most common, which is the contamination. Contamination may be 33% of all presented people with obsessive-compulsive disorder, exactly 6 million Americans in the United States alone, despite of a socioeconomic class, and the same all around the globe. Contamination can be like contamination of geographic areas. Like, for example, I had one patient once upon a time when I was 1991, 1992, who clearly told me that Beverly Hills is contaminated, so therefore I'm not going to go there because it's a contaminated area. Usually this type of magical contamination occurs when people are very lacking the insight, lacking the opportunity to really notice obsessions as not part of themselves. And that is quite a common contamination issue. It could be protecting others, like, if I touch my mom, she's going to get contaminated and die, or if somebody else touches me, I will. Mistakes are very common, perfectionistic concerns, and do remember that OCD in French called la maladie de doute, the doubting disease, and they're precise in their language, which means that they're constantly involved in doubt and inability to make a decision. That's the hallmark of OCD. Please do remember that doubt is. It's the underpinning of OCD. OCD characteristics is major characteristic is compulsions. Now, do remember, please, that there is no other disorder under the sun other than BDD that has compulsions. OCD is the only neurological syndrome that has that. Repetitive behaviors, mental acts that person feels driven to perform in response to obsessions are called compulsions. And for example, checking the doorknobs, whether or not they're locked so no one will steal things at home, or overwashing, cleaning, repeating normal activities, ordering, and neutralizing thoughts, or counting until it feels right. So all of these are compulsions, and there are more. I would like to also indicate to you that OCD characteristic is that it comes in not with 1 or 2 or 3 or 4, but rather maybe 4 or 5 different fear structures that also vacillate. This is why we call it the disease of 1,000 faces and disease of the masks. So we do have one office here at Westwood Institute that is covered by Viennese masks to indicate that OCD is a masking disorder. So these are the characteristics. Avoidances are also present, and I wanted to indicate to you that since it is a syndrome, it's like OCD is in the middle, like sun, and then there are rays there. Usually it would be panic disorder, generalized anxiety disorder, social phobia in many cases, maybe trichotillomania, and skin picking behaviors are common, eating disorders, etc., etc. However, now I'm going to shift to PTSD characteristic that is fascinating, and it was always fascinating to me, because here you take a individual who is completely healthy, right? And then something horrible happens, and this individual is broken, ill, distressed, dysfunctional. So intrusive distressing recollections are related to trauma specifically, to realistic event, whereas in OCD it is not. Recurrent distressing dreams of the event, and we don't necessarily have any dreams or any nightmares in OCD. Psychological distress at exposure to trauma reminders, like external cues, internal cues, which is all in mind, like, for example, going to the same street where the rain happened, or even to the same household, or even seeing, let's say, this bold, tall, 6'3", broad shoulders, and bold man of a particular classification, the man that had raped a woman, she would then extinguished from her life like half of the population, and especially she would not be able to tolerate being nearby that type of prototype of man. And the reminder would be that this could possibly be the one that abused her. Physiological reactivity upon exposure to trauma. There is a lot of physiological reactivity. Efforts to avoid trauma do not really help, because the more you try to avoid it, which is synonymous to compulsions, and OCD has both, there is an increased arousal that causes significant level of disturbances. I can tell you for myself, any patient I ever screen for very little percentages, maybe 2 to 5, that do not have any sleep disturbances. There is a melatonin insufficiency there. PTSD causes a lot of irritability, outbursts of anger, hypervigilance, and exaggerated startle response. PTSD characteristics in terms of the avoidances, synonymous to compulsions, and negatively reinforcing the illness in itself, efforts to avoid trauma related to thoughts and feelings, efforts to avoid trauma related to activities, psychological amnesia, diminished interest, detachment, and restricted range of affect, and foreshortened future. Very oftentimes, I actually interpret this kind of reaction to trauma as dissociation or detachment from the reality, and also by self-defense of restricting range of the affect, inability to feel anything. And in my book, it would be the last step of actually avoiding situations. According to DSM-5, a stressor can be directly experiencing this trauma, witnessing it, learning of traumatic event from close family member and close friend, experiencing repeated extreme exposures. 12 months prevalence among US adults have traumatic PTSD is 3.5%, lower than in Europe, lower than in African Americans. Latin American country cluster is around 0.5 to 1%. Obsessive-compulsive disorder epidemiology is 2.2%, which amounts to exactly to 6 million Americans, despite of socioeconomic class, culture, and upbringing. So it is exactly 6 million Americans, and it is true around the entire globe. Comorbidity with OCD and PTSD. So there is a 12 months prevalence of OCD. Now we're seeing that is 30% among people with PTSD. So prevalence of OCD after traumatic incident necessarily resulting in PTSD ranges, look at that, look at this, from 30% to 82%. It's humongous, humongous percentages. And also, I just wanted to indicate to you right from the beginning, since I am doing this lecture in honor of my dear mentor, Dr. Edna Foa, who had created exposure and response prevention short-term treatments for both PTSD, PE, and OCD, and is being studied in every psychological psychiatric university and facility. So basically, there is a response in 75% for OCD doing exposure EXRP. Comorbid disorders with to the extreme PTSD increases the risk of OCD, including high combat exposure. In Vietnam, veterans with high combat exposures but no PTSD elevated rates to 5.2% of OCD. This illness is very fascinating because it was a neurotic shock in the beginning of last 20th century, and then later on it was renamed. Rate the OCD inverters with low combat exposure and no PTSD is as low 0.3%. So when I was doing this 62-page ADAAs and SCARES, I was going through the entire diagnostic criteria of the individual, the history, as well as comorbid disorders. And oftentimes I would find people who would report trauma prior to the onset of OCD, not necessarily OCD starting at 4 or 5, or having a family member who had OCD. The severity of trauma may disrupt the biological mechanisms, completely get them out of range of working, and the mechanism disturbs the normal thought processes because it's preoccupied constantly with the intrusive thoughts, avoidances, hypervigilance, and inability to sleep. OCD may act as psychological defense as well to prevent an ability to experience the horrific images, impulses, and recollections, pictures from the PTSD. So it is considered to be OCD maybe as a psychological defense. OCD and trauma-related OCD symptoms may emerge very early, resulting in a difficult child who evokes violence and emotionally disturbed parents. And alternatively, there may be a group of OCD patients who exhibit PTSD symptomatology, other symptoms temporarily obscured by OCD. All these hypotheses deserve future evaluation. What I'm trying to do is that OCD is like an onion. You keep peeling and peeling and peeling, and it generalizes to entire life, to all the cues, and finally many people become dysfunctional, or even worse. I've seen a couple of people in my lifetime that were completely catatonic. Other comorbid disorders may have clinical problems with PTSD. Substance abuse is one, not so much with OCD, by the way, depression, panic attacks, eating disorders, somatoform disorders, and obviously OCD. Common consequences include social withdrawal, unemployment, disability, divorce, and homelessness. By the way, we do not take anybody into the program that has been drinking or presently taking marijuana. Symptoms and patterns between the comorbidity and comparisons with OCD. Clusters give clear areas of overlap and interplay, and you need to tease them out because one triggers the other one. It could be usually the internal cue of the memory of the assault or bombing or seeing someone suddenly dead, and then they will start the ritual of cleaning that may last up to 3 to 8 hours. Relationship due to symptoms overlap between two disorders, not to the comorbidity of the diagnosis. Showing you the cluster because we have very little time left. PTSD is re-experiencing real life event with intrusive thoughts, avoidances, numbing, and hyperarousal. No compulsive behaviors. OCD is a syndrome with obsessions, which are definitely not Calvin Klein, but intrusive thoughts, that images that are extremely disturbing, such as I'm not going to contaminate my mother because if I touch her, I may cause her COVID and she is dying. And actually, this is what they see, Or I'm afraid to drive a car. The reason is because there are frequent accidents, and they will tell you how many, and may cause death and substantial harm to the family. Differences between OCD and PTSD. Person with OCD and PTSD may share common set of anxiety-related cognitive judging, unpredictability, and being uncomfortable, and also they are avoidant of any kind of responsibility. That is because it's multi-adult and they don't want to make decisions because they are also afflicted with perfectionistic concerns or commonly found in 50% of OCD patients, OCBT. PTSD, broader and more pervasive symptoms than OCD. Cognitive intrusions are both similar and substantially different in OCD. OCD and PTSD sometimes coexist. Exposure to high magnitude stressor increase for both disorders. So they seem to be exacerbating during the high level of stress, exhaustion, non-sleep. However, OCD generally is underrated to undersetting of the drug. What I'm going to really note, because I will give you this presentation today, and probably yes, but surprisingly, OCD is more common than panic disorder among persons with PTSD, but there is been relatively few studies. So when you see panic, make sure that you treat it first, otherwise all symptoms will come back. So the subgroup of PTSD OCD patients at UCLA back then bothered me a lot because we did the treatment for OCD and all the symptoms alleviated, or some to the extent that we could, with the other comorbidities such as panic and depression and histrionic responses or violent ideation and so on and so on. However, in this early detection, we also must know that there is an underlying PTSD symptoms that will reinforce the OCD if it's not treated with PE, Dr. Fo's method. PE, prolonged exposure, it stands for that. And there is a lot of evidence that 75% improved by 75% of PE, prolonged exposure. And also writing in present tense, creating factory of fears related to the incident. Writing is my panacea. It's one of the methods that I have integrated into the treatment of both OCD, PTSD, and some other anxiety disorders. But this require more complex case management. Remember, you must treat whatever comes and interferes with life most. But since I've been working all my life with OCD, the primary interference has been the OCD symptomology. So, and then if there was trauma that was underpinning, the way I treated the traumatic boy that was catatonic and didn't defecate for 9 days at UCLA, he was 11 years old. When I was called into the child's unit for the first time in my life because they didn't know what to do with the case, OCD pins on functioning. He was just standing there 24/7 in one position and holding hands like that. So I don't know how it happened, but within 4 hours of interviewing and talking to him, he was brilliant boy. By the way, there is evidence that OCs are significantly more intelligent than others. So however important is to determine which is disorder primary interfering. So in general, issues in OCD area dealt first, and completely you try to clean up, the symptomatology, which is not possibly, but by generating the fear factories, if necessary, like write me fear factories as 100 different fears manifesting in present tense for the prevention of the relapse. Traumatized OCD patient may exhibit new previously obscured pathology with OCD. Exposure to trauma will be a very important factor. Psychological vulnerability stemming from childhood abuse may predispose certain patients to OCD as well. I would like at this note, actually, to stop to thank you for the participation and your interest in this subject matter. By the way, even today, and this is almost 30 years later, there is no treatment for PTSD and OCD. They comprise a very, very big amount of people that have a combination of both. They are considered to be treatment refractory, and most people, especially in the United States, where there are treatments that are very well known, but also around the world, are considered to be treatment refractory. In other words, not treatable. But we do have the answers with these 10, in my dissertation, 10 people that we exposed and cleared up the symptomatology of OCD. And then in terms of the Interplay, did a new slate assessment of PTSD cues, external, internal, etc., how it's related to OCD with external, internal cues, and had them write the combinations and similarities and differences, and then work with the method of Dr. Edna for with prolonged exposure. The same method has been used at our VA here in Los Angeles, where I was teaching for 12 years. And I would also indicate there is no better intervention, cognitive, metacognitive intervention, than writing, specifically not typing, but writing in present tense with fear factories, creation, being creative. If you have any questions, I would take them now. I would love to take questions. I can give you the case study of my first case of this boy who was standing like that. So in any case, once he touched me, I said, now quickly touch other things. And before we knew it, within the 3 days of no avoidances and touching the water and not giving it to the compulsions, he was about 50 to 70% better. In terms of symptomatology, he was talking, he was eating, and he did definitely have a bowel movement to happiness and extreme alleviation of our anxiety at UCLA's child department. However, for more information, please visit hopeforocd.com. And there is so much to talk about. However, right now, we're limited with the time, and I was given 30 minutes for this presentation, and I can see that I'm getting very, very close. Look at another case study, for example, if they sometimes sexual or aggressive thoughts may be or may not be related to the trauma, to the sexual trauma. And also the presence of sexual attraction may be a cause for people with OCD and PTSD to think that they're dirty. I would like to also indicate to you that it's crucial to do assessment, to ameliorate all fear structures and attend to them, despite of how many illnesses you have. And when you find panic disorder, please do interoceptive exposure to physiological concomitants of anxiety. Once again, this was Dr. Eda Gorbis. And
thank you so much, Dr. Gorbis. This has been